Ruben. Hello, Ruben.
Yes, good morning.
Good morning, how are you? Actually, Dr. Kontopoulos is giving a lecture, he's finishing in 1 minute.
Excellent, so we can go on.
Okay. Hello again, good morning, Ruben. How are you? Ruben.
Good morning, good morning.
So, we are very happy that you are even with Skype. And here we had a meeting the last 5 hours. And we were talking about several things. But we want your experience on the topic of twin-twin transfusion syndrome, myths and facts. And actually, we would like very much to hear what they are going to say, even from Miami. How is the weather in Miami? Is good?
Excellent.
Excellent.
Yeah,
here is hot, but it's not excellent. But anyway. So please, can you talk about twin-to-twin transfusion syndrome? We know that you are one of the pioneers in this field.
Belong to a separate category called twin anemia polycythemia syndrome, which only occurs in about 3.5% of all TTTS patients. If we use the definition of TTTS after 20 weeks, using a cutoff of 10 centimeters after 20 weeks, that is the myth. The fact is that, yes, the maximum vertical pocket in the recipient twin increases with gestational age, but if you use a cutoff of more than 10 centimeters after 20 weeks, you're going to miss about 1/4 of all TTTS patients. Another myth is that the patients with TTTS usually have a fundal height of 26 centimeters or more. If they don't have more than 26 centimeters, they don't have TTTS. The fact is, we've looked at this, that approximately 20% of the patients will have a fundal height of less than 26 centimeters. And if you take this even to lower gestational ages, like 21 weeks, you can still see that, again, about 1/4 of them will have a fundal height of less than 26 centimeters, even though they do have twin-twin transfusions. One of the most common myths in terms of treatment is that the laser procedure cannot get the deep anastomoses, and this is even as recent as 2016, people saying that when you laser the anastomoses on the surface of the placenta, you are not going to be able to separate the two circulations of the twins. In this article, for example, they said that if you laser at this level, even though you devitalize at this level, you don't devitalize at this level. And so these authors in particular thought that, blood can still go from one twin to the other via this substance in the placenta. The truth is that, no, when you laser the anastomoses, you don't have to laser the full thickness of the placenta to interrupt the vascular communications, the blood exchange between the babies. All you have to do is interrupt the connections. And the extreme of this is an article, for example, that we published showing that, in fact, if you use potassium chloride in one fetus because it has, let's say, a complication like hydrocephalus or any other issues after laser for twin-twin transfusion syndrome, if you inject potassium chloride at one end, this doesn't cross to the other end, and therefore showing in an extreme way that, yes, indeed, when you laser the anastomoses, you do interrupt the communications between the two babies. One of the most classic ones was laser and amniocentesis are the same, and this is being used even today with patients that are being told that if they cannot get to a laser center, that's fine, that they could still do amniocentesis. Well, we know now from the classic Eurofetus trial that showed that laser is indeed better than amniocentesis, not only for survival of 0, 1, and 2, but also for the at least one survivor, and also for in terms of neurological morbidity. So in places, I don't know how many places are doing laser right now in Europe, in places where the patient needs to be referred to a laser center. It is a myth that if she cannot get to a laser center, she's okay to be treated with amniocentesis. And in terms of the effect of the laser therapy versus stage, we also showed that, in fact, the worse the stage, the worse the outcome is with amniocentesis compared to laser treatment. Another myth is that all places have similar outcomes, and we have done analysis of our data compared to Eurofetus data, showing that, in fact, the greater than at least one survival is different, and the most salient one is a comparison of USFetus data versus the NIH study, where, in fact, the differences, for example, for stage 3 and 4 are so remarkable. This is like 87% versus 12%. So outcomes between centers are varying very much, and patients should know how to gauge that, and doctors should strive to get better results so they can reach the known benchmarks about the laser treatment for twin-twin transfusion syndrome. Another myth is that making a hole in the dividing membrane equalizes the pressure between the two sacs. This was a procedure first proposed in Europe and then taken up by some colleagues here in the United States. We did a study showing, in fact, that the pressures in both sacs are exactly the same. This is the pressure in the recipient, this is the pressure in the donor, and this is before any intervention. And this is not going through the dividing membrane. This is putting a needle in each sac. So we're in the sac of the recipient with our endoscope, and then we put a needle to measure the pressure in the sac of the donor, and you can see here that the pressures are exactly the same. So putting a needle in the membrane to so-called equilibrate the pressures between the two sacs is actually not needed to do that. They are exactly the same to begin with. Another myth is that when they actually do that, that causes such a small defect that doesn't have any adverse consequences. So when you put a hole in the membrane, it's such a tiny little hole that is not going to have any adverse effect on the twins. Well, the truth is that, in fact, putting a hole in the membrane is very detrimental to the entire pregnancy. And this particular study showed that even though the outcome was no different between the two groups, you can see here, for example, a very, very small defect recently created from inadvertent septostomy by a colleague that referred the patient for laser treatment, and a bigger hole in another pregnancy with more time between the initial procedure and the laser referral. And then, cases like this, where at the end of the pregnancy, there is absolute, evidence of cord entanglement between the fetuses. So this can go, a little hole can go from here to here to here, and obviously result or could result in death of both babies. In addition, doing the septostomy has other bad things, and that's why it's a fact in red. You can no longer monitor the status of the donor because there is passive transfer of fluid into the cavity of the donor, and you can no longer know if the donor is urinating versus the donor is just getting fluid from the recipient through the hole that was made in the membrane. Making a hole in the membrane interferes with subsequent amnios or subsequent laser because now you have a membrane that is waving in front of you and doesn't let you do the surgery. And also that if you were to have a complication with rupture of membranes of twin A, for example, now you also have rupture of membranes of twin B because basically you have now a single cavity. If you didn't make the hole in the membrane, then you wouldn't. One second. It says that there's a problem with the connection, or are you hearing me well or no?
Yeah, it's okay.
Okay. I have a text message here from Athens saying that they have a problem with the connection. Anyway, so if you make a hole in the membrane and you have ruptured membranes of A, now you also have ruptured membranes of B. So making on the membrane is not a good idea. And obviously cord entanglement, as we mentioned. Another myth is that you should do a test amniocentesis, and if it doesn't work, then you should proceed to do laser. Nobody knows where this came from, but in fact, we did show that in about 1,000 patients, about a third of them were referred to us already with a prior amniocentesis. And you can see here that in 8% there was membrane detachment. And this is from the article that we published on this particular series. What you see here, this is not the amniotic cavity. This is the chorionic cavity. So this membrane was supposed to be up here. It is now completely collapsed. This is the recipient twin. This is the donor twin. So this membrane is now completely detached from the uterine wall. It's essentially impossible to do the laser therapy in this case, because the placenta is here and you would have to be inside this sac to do the treatment. Now, we did show that you can change this situation to this situation by doing an amnio patch. So we patched this cavity over here with an amnio patch. 1 week later, the hole that was here initially sealed, and this one went all the way back to the uterine wall, and that presented this cavity now, let's say a week or two later, which allowed us to do the surgery and take care of the twin transfusion syndrome. The other thing about prior amnios is that the gestation age of delivery is affected. So here you see anywhere from, more than a week difference, and the need to do other procedures like exchanging fluid, etc. Anyway, so doing a prior amniocentesis, if you're going to do laser, is not a good idea. If you're going to do laser, just go ahead and do the laser and no test amniocentesis. Another myth is that laser cannot be done in patients with an anterior placenta. Many patients here in the United States are turned away from many centers because they have an anterior placenta and they are told, different things. Well, as you can imagine, anterior placentas, the incidence of anterior placentas are exactly the same as posterior placentas. They should be about 50-50. And you can see from our data, and this is published, more than 10 years ago, that the likelihood of survival, whether it's an anterior or posterior placenta, is exactly the same. So the issue is not one of the location of the placenta. The issue is one of being able to address the surgeries regardless of the location of the placenta. Another common myth, although this is gone a little bit by the wayside, is that superficial anastomoses are in fact protective. We did studies looking at the types of anastomoses that the placentas can have, and you can see here in yellow that either they have mixed anastomoses where they have superficial and deep, and about 5% of them or 4% of them have only superficial anastomoses. So basically about a quarter of all TTTS patients will have superficial anastomoses. And you can see here, even in the distribution by stage, that the presence of superficial anastomosis is distributed throughout, all of the different stages. So superficial anastomosis obviously don't protect, having TTTS. This should be zero. If they were protected, they should be all zero, and they're not zero. They're anywhere from 17 to 34%. And then in terms of survival, the survival is not affected by the presence of superficial anastomosis. So it should not be an issue in terms of classifying them with or without superficial anastomosis, or assuming that if they have superficial anastomosis, they're going to have a better prognosis than if they don't have superficial anastomosis. Personally, I find it easier to do a laser in patients that don't have superficial anastomosis because they are typically bigger or more challenging. But regardless, the myth is that TTTS did not occur in the presence of superficial anastomosis, and it does occur, and it occurs often enough that you have to know how to address them when you are actually doing the surgery. Another myth, this was also early on, was that TTTS doesn't occur in monoamniotic twins, and the rationale there was that the cords were very close, that they have a lot of anastomoses, a lot of superficial anastomoses, etc., and that therefore you will never see a monoamniotic twin gestation with TTTS. Well, the truth is that this is a statistical issue because obviously monoamniotic twins are rare. They're only 1% of all the monochorionics. And if TTTS occurs in only 10% of monochorionics, then the likelihood of you seeing a TTTS patient in a monoamniotic twin is 1 in 1,000 monochorionic twins. So I don't know, in any institution, you know, when they reach having seen 1,000 monochorionic twins, that's when they're going to see a TTTS in monoamniotics. And the second issue is that obviously, because there's no dividing membrane, then you cannot know that the donor has oligohydramnios. So you wouldn't be able to make the diagnosis of a stage 1, for example, TTTS case, because you wouldn't have a dividing membrane to tell you that there is oligohydramnios in the donor twin. Another myth in terms of surgical pathology is that, and this came from London, saying that there is typically only one anastomosis per placenta in TTTS. Well, the truth is that several studies have shown that the average number of anastomoses is anywhere from 3 to 5. Certainly in our laser data, we have confirmed this as well. The range goes from 1 to about 18, but the median is about 4 or 5 anastomosis per case. So this issue that there was only one anastomosis and that was the culprit of this disease is also one of the myths in TTTS. Another myth, and this was shown in many slides around the world by different investigators, was that when you do laser, you produce a full necrosis of the placenta. Well, certainly that's not the case. When you are gentle, when you do a selective technique and you only laser the anastomoses, as is shown on this slide with those little white dots, so the entire placenta is otherwise preserved and you're not deteriorating, the substance of the placenta as has been suggested. These are examples of selective technique with the groups in Holland showing how, in fact, even with a Solomon technique, they don't produce full necrosis of the placenta. A more common myth is that the Solomon technique is better than the selective technique, and this was from a study published in 2014, a randomized clinical trial comparing Solomon versus selective technique. The idea came from the fact that the rate of patent vascular anastomoses by the groups was being reported as very high, approximately 33%. And so they wanted to change the surgical technique because in their mind, they were probably missing anastomoses that they couldn't see when they were doing the laser therapy. And so the idea was, if this is a placenta with anastomoses being lasered here in the yellow, then the idea would be to use the laser and connect all of the different points and occlude, the tissue in between the anastomoses to make sure that you haven't missed any anastomoses in between. Now, the purpose of the study, in fact, was then to test whether the Solomon technique could prevent the occurrence of residual anastomoses with their associated complications. And what the study showed, actually, is that the rate of residual anastomoses in the Solomon technique was 19%, and in the so-called standard technique was 30%, and this was actually not statistically significant. So if you go back to the original purpose of the study, which was the Solomon technique is supposed to reduce the incidence of residual patent vascular anastomoses, then their own study, that study showed that in fact the Solomon technique did not reduce the incidence of patent vascular anastomoses. And you can see that here in a graph where the incidence is 19% in one group and 30% in the other group. and this difference is not statistically significant. So where does the confusion come in? Oh, because they changed the primary outcome to suggest that the outcome is now going to be recurrent TTTS or TAPS. Well, that wasn't the idea of the study, and therefore, changing the primary outcome in the middle of the study is not how you do a randomized clinical trial. So right now, groups are quoting this article to suggest that the Solomon technique is actually better, when in reality the Solomon technique is not better than the selective technique. And obviously, our incidence of patent vascular anastomoses is not 30%, is not 19%, it's only 4.8%. So another reason not to, let's say, go with the myth that you have to laser healthy areas of the placenta in order to make sure that you have identified and occluded all of the vascular anastomoses. There are other myths out there. For example, you don't need surgery, you just have to drink high-protein shakes. That's a myth that we don't even have to deal with. Laser destroys the evidence. Well, you have to laser anastomoses. You cannot leave them patent. And so I don't know how to address that kind of myth or that kind of issue. The superficial anastomoses are bidirectional. Well, we have shown that they function as an AV anastomosis depending on the blood pressure prevailing on one side or the other of the anastomosis. And so they're not really bidirectional. Bidirectional function is only a subset of superficial anastomosis. Most superficial anastomoses function as AV anastomosis depending on who has the higher blood pressure, the donor or the recipient, typically the recipient twin. There is very chance for survival if you're less than 22 weeks. Well, actually, the mean gestational age at surgery is about 20. So when we do these surgeries at 20 weeks, we still have a greater than 90% chance that at least one baby will survive. So that's not really an issue. Another one that's common is, well, if you've had the laser surgery, we need to do a cesarean section if there is death of one baby removed from laser, and the answer to that is no, because if you have occluded all the anastomoses, then that pregnancy behaves like a dichorionic pregnancy, and therefore you should not be in need to deliver the other twin if the co-twin dies. So in conclusion, because I only have 20 minutes, again, there are a number of questions that have been raised about this particular disease, many of which are either based on lack of information or misinterpretation of actual data. But in reality, the facts are coming out either slowly or consistently to dispel many of these concepts, many of these thoughts, and be able to tell patients the truth about TTTS, how to diagnose it, how to counsel for the best management, and obviously how to treat them and how to give them the best prognosis. So that's what I had for you this morning, and I'm going to pass the microphone now to Effie.
Good, thank you very much. Thank you very much, Ruben. We're waiting also for Effie to give her lecture, and then maybe we are going to have 5 minutes just for some questions that the people they have here. Okay?
Beautiful. Okay,
Good.
So here's Effie. Bye-bye.
Bye.
Good morning, everyone, from Miami. Kalimera.
Good morning, Effie. Kalimera. Actually, your brother is here, and where's your brother? Somewhere here. Yes, back there.
Yes.
And your father is here. Good.
So I can't hear you. I'm sorry.
And your father and your brother are here. So be careful what you are saying.
Good morning to all.
Okay,
I
good.
hope you're having a wonderful day. So I just want to be brief with my talk and stay in time. So I'm going to discuss about discordant anomalies and monochorionic twins this morning. So I'm sure, as you all know, the most important factor for identifying mortality and categorizing twins is placentation. starting off with dichorionic diamniotic twins that have separate placentas. We have dichorionic diamniotic can have separate placenta or a fused placenta. Then we have monochorionic diamniotics that have a single placenta, and that's about 36% of the time. And as you all know, I assume, then we have monochorionic monoamniotic, which is the most rare group that have a single placenta and no separation. Interesting though, the mortality in these groups is almost reversed to the incidence. As you can see, monochorionic monoamniotic group, which is the most rare, 0.02%, has a mortality rate of 44 percentile. And the ones that are in the monochorionic diamniotic category also, although less, have a mortality rate of up to 33%. How can we explain that? I'm going to go over that with you in the next few minutes and show you how specifically also some of these anomalies could be concordant or discordant. The mortality patterns, as you can see, are higher in the monochorionic monoamniotic group and monochorionic diamniotic. And what is that driven from? We know that chorionicity is the most important part of this, and monochorionic twins have 3 to 4% higher than dichorionic twins in the mortality overall. In the first trimester, as you can see, the dichorionic twins can be identified with the identification of 2 yolk sacs and 2 sacs. And the monochorionic diamniotic, obviously, with the separation that will later on become a thin intra-twin membrane. Now, these are the dichorionic diamniotic group versus the monochorionic diamniotic group, which plus the thin membrane in one side versus the very thick membrane in the other side. And in the second trimester, we look for the identification of the twin peak sign versus lack of it. And also it's very useful to look sometimes at the sex of the fetuses that can help us identify or give us hints for the zygosity, obviously, and the chronicity. And you can see chorionic is thick septum, twin peak sign present, monochorionic, very thin septum, T sign present. Now, some difficult cases, for example, this is a case that we saw recently, and this was sent to us again for twin-twin transfusion syndrome. You can see this fetus here with a very thin membrane attached around it. But then after we looked endoscopically, this was a very opaque, thick membrane. That was a very rare case, was this actually was not what we expected, the typical monochorionic diamniotic. It was actually a dichorionic diamniotic twin gestation. And also another case where typically one would think that these placentas appear completely separate. And as a matter of fact, after investigation, there was a monochorionic diamniotic, but it was a bilobe placenta. So these fetuses are actually identical in this pregnancy. So are there specific complications in monochorionic twins? As we said, is twin-twin transfusion syndrome, selective intrauterine growth retardation, twin anemia, polycythemia, sequence much known as TAPS, and TRAP, which is twin reverse arterial perfusion. Except for prematurity, which is the leading cause of mortality, we see that anomalies in these twins estimates approximately to 11%. And the frequency of anomalies actually, in parallel with the mortality that I previously spoke about, is higher in the monochorionic group, much more than the other ones. We know that in twins overall, you can have, let's say, specific complications to twins. For example, unique vanishing twin, twin-twin transfusion syndrome, a cardiac twin, conjoined twins. But those that could be different in between the twin could be rhesus disease infections and overall increased frequency, as you know, a whole big list of anomalies. So why is it important to look at congenital anomalies in twins? It is responsible for 15% of perinatal mortality, but indirectly responsible for 40% of perinatal mortality due to prematurity. And I'm going to explain a little bit because this is a very big number compared to what we discussed. And what do we say is an anomaly? Any deviation from the normal that we would expect. It could be a malformation, it could be a disruption, it could be a deformation, or a sequence of anomalies that derive from a presumed singlet, the underlying effect. These anomalies in monochorionic twins could be concordant or discordant. By that, what I mean is that both fetuses can have the same anomaly, and that will be the concordant group, or one fetus can have an anomaly, although they are monozygotic, I repeat, and the other one not have it. And these are very rare cases that we see in our fetal center that actually are sometimes puzzling. So how many times can these twins have an anomaly? Almost 20% of the time, as you can see. Concordant, 70% can have one anomaly. 30% of those groups could have different anomalies, and that could be differences to several factors. There could be postzygotic mitotic crossing, imprinting difference, and epigenetic differences. There are studies shown that there could be differences in epigenetic and phenotypic heritability, and we see methylation causing these, DNA methylation causing these differences in the twin pair. Possible epigenetic mechanisms can explain this discordance, like differentiation methylation and, differences in the inner cell mass after the splitting. And epigenetic changes in their different transcription of diseases, showing that there could be a suppressed transcription in one fetus versus the other in the monozygotic pair. In addition, there could be dyskaryotic monozygotic twins. So there could be for example, a Turner syndrome fetus on one side and a normal one on the other one. There could be chromosomal abnormalities, duplications, deletions, again, unique to one or the other, or monogenic disorders. For example, there are case reports of even, let's say, Bodesac anomaly, bladder extrophy, even syndromes of monogenic disorders in one versus the other, which is a whole list. But also, interestingly, even if they are having the common monogenetic disorder, both of them, there are times where the phenotype is expressed differently, even if they have the same one. Now, even in twin-twin transfusion syndrome, where we assume that the fetuses have to be identical, there's 3 times higher incidence of congenital heart disease than singletons, and we see that in ventricular septal defects, ASDs, and pulmonary stenosis. In monochorionic monoamniotic twins, as one would expect, almost 1/4 have an increased rate, 25% increased rate in the congenital anomalies. So, talking about myths and facts, as the previous speaker, yes, the myth is that they're all identical, but the fact is that sometimes, although identical, they're not the same. So, depending on the effect that this can have overall to the pregnancy, we have categorized these twins into their effect for the twin to the co-twin. So, if, for example, there's an intrauterine fetal demise of the anomalous twin from the effect of the anomaly, we say that this will be a direct effect to the other twin. There could be also, let's say, hypotension of the co-twin as a result of placental anastomosis, for in the effect of twin-twin transfusion syndrome, when one fetus has 30% likelihood of dying due to its co-twin. Or it could be neurological damage from twin to the normal twin because of the death of the one twin or delivery earlier in gestation. On the other hand, there could be an indirect effect. Although there may not be co-demise of the twin as this in this case, if the fetus has an anomaly on one side that has, let's say, extreme polyhydramnios, that could cause preterm labor or miscarriage. That could be an indirect effect of the healthy co-twin. So, examples as GI obstruction, anencephaly, neurological disorders where the fetus has extreme difficulty swallowing amniotic fluid and causes polyhydramnios indirectly, or chromosomal anomalies. These may cause preterm labor and miscarriage, and that can have the indirect effect on the co-twin. And of course, there's the third category of the nil effect, where the anomaly has no effect whatsoever on the prenatal course, but is lethal postnatally, potentially or not. So we have created an algorithm of management of these rare cases of monochorionic twins where one is healthy and one is not. Let's look at this example of trap sequence, which is very characteristic of this group of fetuses. And as you know, sure you know that in the trap sequence, we have the pump twin, that is the one that has increased cardiac load, high output, has polyhydramnios, and eventually ends up with hydropic changes. And the recipient, which is the trap twin, which is the anomalous twin, and that one also exchanges the blood with the pump twin through the characteristic circulation. So in the case of trap, it's very important to demonstrate that we have the umbilical vein coming from the trap twin and the artery coming from the healthier fetus. And that's very important also for the treatment of fetal therapy. We know that the perinatal mortality in the trap sequence is up to 50% of the healthy twin. And that's very high, considering that 25% of twins, it can happen in 25% of twins. So with a cardiac twins, or otherwise called trap, this syndrome can lead up to 50 to 75% of pregnancy loss due to polyhydramnios that could lead to miscarriage and therefore loss of the of both twins, or congenital heart failure of the pump twin, the healthier twin, and therefore demise. In these cases, we offer what's called ligation, umbilical-cord ligation of the trapped twin in order to save the life of the healthy twin and continue with the pregnancy. There are several methods used surgically to do that, but we prefer surgical ligation or laser photocoagulation of the umbilical cord, as we think that our studies have shown that it has less complications, less side effects in the long term. But all of these are available. So our rationale is that, as you can see in my algorithm, that if we have in group 1, there is in utero demise. So therefore, let's say in trap, yes, there is a hemodynamic problem that can cause in utero death of the co-twin and compromise of the co-twin. And therefore, we absolutely need to offer fetal therapy. Another example is anencephaly of the monochorionic twins. You see here we have on one sac a fetus that has a normal cranium and is a normal fetus, and that's the one on the right, versus the one on the left where you can see a crania, and these are monochorionic, diamniotic, clearly. So we know that 50 to 60% of these fetuses have, can create an IUFD and affect the other fetus. And again, that will be in the category where we have group 1. And because it can cause a fetal demise, then we would offer treatment in order to save the healthy baby. Let's look at group 2, though, which is a little bit different. Here an example of duodenal atresia of one twin that came to us. So one side had a fetus with duodenal atresia that caused polyhydramnios eventually, and the other twin was healthy. And in this case, we are in group 2 where, yes, there is no risk for in utero death per se, but indirectly due to the polyhydramnios, there is compromise with the co-twin, and therefore there is an indication for fetal surgery and cord ligation if need be. On the other hand, there's post-lethal anomalies. For example, let's say bilateral luteal genesis, where the fetus will not compromise the life of the co-twin during pregnancy, but because it has a very poor outcome postnatally, the patients may seek treatments. Or it may not be lethal, and that will be the fourth category, so it's not graded properly, where we can have dandy walker or some other abnormality. It's not lethal, and doesn't compromise the co-twin, but patients come for potential counseling and potential seeking for fetal therapy. So, in conclusion, discordant anomalous twins present a counseling and managing challenge because first of all, these twins are theoretically identical, but in rare cases have very rare anomalies in one sac versus the other. Counseling and management may be huge in impacting how we're going to understand and manage this. The allocation of discordant twins into management groups that we have created, this algorithm, may facilitate actually who we choose to offer fetal therapy and who we don't. And fetal therapy should be offered only after strict criteria are met. So, thank you. And we're open for questions.
Thank you very much, Effie, for excellent presentation. Thank you. I think that as we go deeper and deeper in this topic of twin pregnancies and the discordance of monochorionic monozygotic twins is very, very important. And we had some very interesting, from Greek colleagues, some interesting presentation, even though with epigenetics in twins and so on. But thank you. It was excellent presentation, and Ruben's presentation also was, as always, very deductive and very nice.